The last domain that we are going to talk about and discuss is quality. And just like cost, quality actually can be viewed into two different perspectives. And it's basically the same, one from a micro perspective point of view, and another one from a macro perspective point of view. So micro perspectives look at the services when it was actually given to the patient. So it looks at how that service was actually given in terms of quality to the patient. And because it's micro perspective, it's looking at the performance of one individual provider, or it can also look at the performance of a larger organization as a whole, say for instance an entire clinic. Now macro perspectives look at quality from the population standpoint. So it's really not just one particular provider or how that service was given. It looks at more on the outcome, meaning it's more of the reflection of the performance of that particular healthcare service that was given. So in other words, the quality of service that was given on the micro perspective, did it actually have an effect on the entire community for which that healthcare service was made available? So we're now looking at the effect on a group of people, whereas here we're looking at the effect of that particular service or how it was given to a particular individual that is a member of that group. So here's a table from your textbook. These are examples of indicators for quality in healthcare. So for micro level, there's basically small area variations. There's variations in specific healthcare services, for instance, in different areas, in different geographic areas, locations. And then medical errors. So again, it's looking at when that service was actually given. It's at the point of service. Patient satisfaction is also micro level because you're looking at how the patient himself or herself perceives the quality of the service. Now, quality of life, although it could be an outcome, is still considered micro level. So quality of life is like how satisfied a person is, and the resulting quality of life from that particular intervention, healthcare intervention. And then health outcomes. So health outcomes can sometimes also be looked at macro level, but in terms of health outcomes, say for a particular patient, this could be considered a micro level. Now macro level, on the other hand, like we mentioned from the previous slide, looks at population health. Did it improve the health of the entire population, say of a country or the entire city, like New York City? Did we actually reduce lung cancers directly attributed to tobacco smoking, because we have one of the lowest smoking rates in the country? And then here is proof that if you actually look at certain domains, one of the domains, for instance, quality, it's going to affect cost as well as access to healthcare. So they are all interrelated. Let's talk about this social scientist. He's actually a physician who put together this paradigm, this way of thinking on how quality in healthcare should be looked at and how it should be examined. And he said that there are three domains, there are three aspects in quality of healthcare that need to be looked at, and they're all equal. First is structure, the second is process, and the third one is outcome. And we're all going to talk about each of them individually. He says that all of them are important in measuring quality. So how you actually measure quality cannot just be examined through outcomes. Did the population become healthy? Process, which is, are we doing it the right way? And then structure, which is the environment. So he says that all of these three things are complementary, and if we're going to examine quality, we have to look at all three of them. So this particular paradigm that Avidis Donabedian put together is called the Donabedian model in examining quality of healthcare. So he was a physician and a health services social scientist researcher at the University of Michigan. And this model goes way back to more than 50 years. And he developed this in 1966. No matter how long ago he actually put this together, the Donabedian model is still the dominant paradigm in how social scientists assess the quality of healthcare in the United States. So let's look at the first domain that he proposed. The first one is structure, and he defines this as the relatively stable characteristics of, first, the providers of care, of the tools and resources that are available to them, and the infrastructure and the environment in which these providers work out of. So this could mean, tools and resources like the building, temperature control, things like that. These are the stable characteristics. So these are the physical aspects that they need. For instance, is there an available syringe? And it's always available, and you don't waste time because it's always available if you need it in an exam room, things like that. Now, not only is it referring to the physical aspect, it's also looking at the organizational setting in which they work. That means it looks at organizational psychology, such as health systems and human resources. That is why in any type of organization, you have an HR office, a human resources office. The next domain that we will look at would be the process. And the process is the specific way in which care is provided to patients. So what are the guidelines? How is it done? So are we actually doing correct diagnostic tests? Are we running, say, or are we doing what we're supposed to do if we want to find out if this child has a strep throat, or if anyone who walks into the clinic and suspects that they have a flu, are we doing the right diagnostic tests? Are we giving the right prescription? So if the type of infection and the type of causative agent or bacteria is susceptible to this type of antibiotic, is that the one that we're actually giving? And of course, accurate drug administration. So this also goes to what we're going to talk about towards the end of this section, which is patient safety, because giving accurate drug administration is one of those things that have caused some problems and have actually endangered patients in the past. There are currently some developments in process improvement. So under process, there are certain things that are actually being initiated or being put in place. So if you remember when we watched that video about when we were talking about the history of medicine, one such thing, for instance, is the checklist that Dr. Atul Gawande put in place in the operating room in surgical theater, and it has actually brought down a lot of avoidable errors. So these are what we call clinical practice guidelines. They are also called medical practice guidelines, and they are the ones that are preferred clinical processes. For instance, how do you take care of diabetics if you are seeing diabetics in a primary care? So there are several things you're supposed to do. You're supposed to check their A1C every 6 months or every 3 months, depending on the level of glucose control they have. They need to have annual foot exams and all those things. And they are all resulting from a guideline that was published. Now, these guidelines don't come out of thin air. They are usually put together by experts in the field and practitioners that are experts, say, for instance, in taking care of diabetics. So this is basically a plan of care on a particular clinical problem, and it's based on evidence. And in this case, we were talking about diabetes, and it provides some sort of a list of things and a protocol on what to do in physician's clinical decision. So, for instance, what are you supposed to do if you can't really control the blood sugar? So maybe you might need to send the patient for secondary or tertiary care and get seen and ask for a consult with an endocrinologist. And the intention is to lower cost and have better outcomes, get better outcomes for the patient's wellness. And in this case, again, in the example that we used, control of diabetes. Now notice that cost is here because cost is an important domain of the iron triangle. The next concept or development in process improvement that we will touch on is cost efficiency. So the next concept or development in process improvement that we're going to talk about is cost efficiency. So cost efficiency is also referred to as cost effectiveness. And something is cost efficient when the benefits you get out of it is greater than the cost incurred. So we're talking about, say, for instance, Pap smears, which is a very effective screening tool for cervical cancer, or colonoscopy, which is a good screening tool for colon cancers. Now, these procedures do cost money. You have to pay for the providers who do it. They train for years to be able to do this. The handling of specimens, equipment itself for colonoscopy, for instance. But if there's no colonoscopy, there will be more people that will have developed colon cancer at a late stage. What these screening tools do is, which makes them cost efficient, is that when you do the screening, when you use the screening tool, you're actually able to catch the disease at a very early stage, and therefore you prevent it from worsening into a situation where, say, for instance, it becomes a stage 4 cancer. Now, the point is optimal quality, and there is a demarcation between underutilization and overutilization. What does this mean? We need to meet halfway and at midpoint, because if we do not utilize the screenings, for instance, then it is not going to be cost efficient. Or if we overutilize it, then it is also not going to be cost efficient. So there's now some guidelines, for instance, on Pap smears or for mammograms, because there was this belief that it was being overutilized, and it's not really catching things in a cost-efficient manner. That's why there are now specific guidelines. But these are just guidelines, and it's always advised that if, say, for instance, you have a family history of cancer, that's why you need to have a relationship with your healthcare provider, because the decision will always be done by the two of you. The next development in process improvement is critical pathways. So critical pathways are sort of similar to clinical practice guidelines. But this is more specific because it looks at outcomes, and the plan the plan of care is patient-centered. So there are case management tools that people use, and it's not just one provider, it's interdisciplinary. It basically creates a plan of care wherein multidisciplinary professionals, healthcare professionals, are taking care of this patient. So if you remember the video we watched about Isaiah, and Dr. Berwick was basically saying it was a symphony of healthcare professionals and case management. And it cured Isaiah's leukemia. And that's basically what he was saying and talking about. It's called critical pathways. It also provides a schedule when an achievable outcome is supposed to be reached, and that, which is the culminating factor of that plan of care itself. The last development in process improvement that we'll be discussing is risk management. So risk management is simply those proactive efforts that are geared towards. So the last domain of the Donabedian model is outcomes. And outcomes is the final result or the effect of everything that was done in healthcare delivery service based on the structure and the process of the healthcare delivery itself. So it's like, what is the result that happened with the way things were done and in the environment it was done? Did it actually result in the improvement of health status? So this is viewed as the measure of how effective the healthcare delivery system is, because it is something measurable, and it's something like you could put a number on and quantify, like how many of the members of that given population, how many of them have controlled their diabetes. So some measures include infection rates, rates of rehospitalization. So rehospitalization is actually people being rehospitalized within 30 days for the same reason. We don't want that to happen because we want people, once they're released out of the hospital, to have gotten better because of the structure and the processes that were utilized in giving the healthcare delivery service. And of course, also patient satisfaction. We cannot complete the discussion of quality if we don't talk about patient safety. So for quality, it's a measure of how good the performance of the healthcare delivery system is through better clinical and health outcomes. But safety is something that cannot be ignored. It is part of healthcare quality, because safety simply means that there is the absence of errors that compromises the results of the healthcare delivery services that were given, which then affects the quality of care. If safety is compromised, it could reduce the clinical and health outcomes, effective and satisfactory clinical and health outcomes. So what is a patient safety event? So it's anything that happens where there is an act of omission. So it could be a process, it could be an act of omission, or something that is done that causes hazardous healthcare conditions or unintended harm to the patient. So that is a patient safety event. For instance, you've probably heard of patients receiving more than the correct dose of medication, things like that. So those are patient safety events. Let's look at some examples of safety issues. So failure to capture and maintain accurate, comprehensive clinical information. So this could actually be very dangerous, because if not enough history about the patient is recorded or kept in the medical record, it could result in certain actions by other providers that are part of the team that could jeopardize the health of the patient. For instance, if this provider doesn't know that this patient is on one particular medication, and then this other provider gives medication that could counteract in a bad way with that medication that was given, then it could harm the patient. So another one is failure to maintain medical equipment. So that's more of like a structure, domain of quality. And then the processes or the way things are done, associated with medications that could be sources of potential risk. So for instance, blood thinners and things like that. and diagnostic errors. So that's also one of those things that we look at. So what are the ways that are put in place to reduce the risk for patient safety? So what are the efforts that are put in place? So one would be pharmacist-led reviews of medication, not just by the physicians, but the pharmacists who are experts in this. Improving accuracy of electronic prescriptions. One additional zero, for instance, in a dosage could be fatal to a patient. Educational interventions in service, educational interventions to medical students, and not just medical students, but medical practitioners, physicians as well, peer review. And then something put in place wherein a patient safety event is reported properly, and it's done through proper channels, and there's no repercussions. It literally goes to the right person or the right office in a particular health system. And of course, enhancing patient safety culture. So we will watch a video after this actually that looks at patient safety culture. So to conclude this session, the greatest challenge to healthcare is really increasing cost and then inequality in access. And there are some concerns about quality, because if you look at health indicators and compare us around the world with those that spend less than we do, they have better health indicators than us. For instance, we have still a very high infant mortality rate, which is the death of infants before they turn 1 year old, and also maternal deaths. Like there are still a lot of, especially women of color, dying during childbirth. And because of this, we also need to deal with the high healthcare costs in the United States, because it is the highest in the world, but we don't really have much to show for it in terms of health outcomes. So that's the end of this lecture video. There are 2 more videos that you should watch after this. And of course, after that, you would be able to access your assignment.